Are people dropping in?
Indeed.
Yeah. So we are live on YouTube.
Yes, as well.
So I can say to my kids that I'm on YouTube.
A real influencer.
Yeah. I got a lot of advices for Brain and Spine for the new journal about social media. And after my first discussions, I said, well, there's nothing for our generation. So the young generation should take care of this. So I think there are quite already some participants. I'll wait a little bit more, a few seconds before starting to welcome. So we are now above 60. So that's already a great number. It is 1 minute past 5 o'clock. Welcome all to this webinar organized by the EANS, especially by Anna. Many thanks for that. And also thanks to Niklas, who made it possible that as a trauma section, neurotrauma section of the EANS, we can have these webinars, which normally would have been performed during a congress. The title of the webinar is a little bit tricky maybe, or cryptic. It's called Clinical Trial and Error. It will be, well, you will see it during this first hour, why it is clinical trial and error. The reason we decided this title as speakers of this webinar is that in a lot of neurotrauma cases, there's not much evidence. And when we treat, we do that based on our feeling. And that's sometimes intuitive, not very academic. And during that decision-making and acute phase, we sometimes make mistakes or errors. And not mistakes which are mistakes in the wrong sense of the word, but decisions which maybe we shouldn't have taken. But as evidence is lacking, we will have to discuss that afterwards. So that's the reason for clinical trial error, but the whole hour will be done by Dana Hall, who's a resident of neurosurgery in Rotterdam in the Erasmus MC, Thomas van Essen, who is a resident of neurosurgery in Leiden and The Hague, and Jeroen van Dijk, who is also a resident in Leiden and The Hague, and all three are busy with a PhD thesis connected to neurotrauma, and they will discuss their experiences and also the drawbacks. It's very important when you want to ask a question during one of the presentation, you cannot interrupt us, but you can place a question in the box questions and answers. It's Q&A. So not in the chat box questions. The chat box is for chatting. Hello, how are you? And things like that. But questions about scientific content, you can place there. And I try to follow them up as a moderator. The first speaker, that's my, the other people should say who I am, but I'm Wilke Pul, some of you might know. And I try to share my screen with PowerPoint presentations. And for me, it's also the first time that we do a webinar with 4 speakers. So it's also a bit tricky in time, but hopefully we are in time, and it will be a lot of fun discussing things with each other. So this is already the title we just discussed. I have quite a few conflicts of interest. Besides working as a neurosurgeon, I'm also doing a lot of neurotraumatology. So I have some prejudices in favor of doing surgery compared to conservative care in trauma patients. And I also have some industry-related sponsorships, but not with brain trauma. So as you all know, neurotraumatology is not only brain trauma. A lot of people think it's connected to each other directly, but all of you know that neurotraumatology is also peripheral nerve trauma, which is very important for neurosurgeons to keep hold of, because we can lose a lot of that. And that's also one of the discussions we had during the journal meetings. Why is it not brain and spine and nerve? Well, that's difficult in the title, but nerve will be content. and also spine trauma, including spinal cord injury. But we are now discussing TBI. A lot of research which has been performed and is still being performed by Center TBI, you can read about in this Lancet paper. A lot of you have heard of that. Not all of you have read it. It's a very large supplement of Lancet, and you can look into detail how research is being done in Europe by Center TBI. And most of you are also familiar with the Track TBI in the United States, North America. So what is the conclusion of all those studies we look until now? That a lot is not unknown. So if we look at neurosurgery alone, then we are looking too narrow-minded. You have to look at everything from the moment of the trauma back into reality and integration. And sometimes people don't go back into reintegration, and please don't close your eyes for that. I did it for quite a while. I didn't see my patients back, which were not very well after our treatment. This is also what you all know. It's quite heterogeneous, and it's not that you already know it, but for research, that's quite difficult. So the speakers after me will come back to that. So every trauma might be a brain trauma, but if the cause is different, then the result in the brain also is different. So this Center TBI, and these are the big masters, the master planners of this study. In the past, it was a kind in a brain trauma, kind of neurocritical care, gypsy foretelling. While in the near future, in the next 5 to 10 years, hopefully, we can predict a little bit more. So some of the studies will allude to that and also be discussed. And you all know the RCT done by Hutchinson in Cambridge and Ali Angelos Kolias. It's a quite difficult RCT. They did a very big job. But after this job, they showed the result, and there was a lot of discussion going on that we have a little bit more people in a very severe disabled state. So more survivors, but more disabled state. And the discussion goes on, what is favorable and what's unfavorable? Well, I don't like the word unfavorable, so we should look for another term for that. But we still are not able to predict in which class a patient is falling when the patient is in the critical care unit. So in very severe TBI, we are still having our protocols, but a lot of our treatments are intuitive. And every time there's a discussion, do we let the patient live or let the patient die? And we all know it, but if you see it in text, live or let die, it's quite hard. It's quite a hard fact that we have to discuss that. And also very emotional for the patients, but also sometimes for the treating team. So day to day, you all work with clinical dilemmas. And every time you have to decide yes or no. And one of the speakers today, Thomas van Essen, and also Jeroen, but Thomas van Essen was very busy with a small child last Friday, and it was very emotional, but it was also yes or no. Do we do a hemicraniectomy with a high ECP in a very small child, yes or no? And we never do it good. And that's the reason that it is trial and error. And we learn from that. And if I learn from that, even at my age, I'm not that old, but I'm a little bit older than the PhD students we were talking, then we are still learning. And the next time you act differently, and then you make a mistake the other way around. So this is, you show a lot of you have seen earlier presentations about brain trauma, and I always refer to this publication. I won't repeat it, but we cannot do randomization in a life-threatened patient in which there's a life-saving treatment. So then there are different trajectories for that. After Dana will talk about the difficulties to do an RCT, Thomas will discuss the methodology of these problems which you face in comparative effectiveness research. So the next hour is by the young speakers, and this is a slide I get, a photo which I received from one of our neuroradiologists, Geert Liekema, And he said, well, if you talk about first author, second author, and PI and things like that, what's the succession in the author list? Well, the most important thing, it's a team, and in the team you can rise it. But it's very important that the next speakers are all the, in my opinion, the principal investigators of those studies and are able to defend it a little bit better than I. So this was my presentation. This will be the succession. Dana will speak about the cooperation within a seemingly easy RCT, the Dexa. Thomas about methodology in severe TBI, and Jeroen van Dijk will talk about moral dilemmas in very severe TBI. And I wish you all good luck. Dana, you can try to share your screen. I will stop sharing my screen. And
so I will not speak on treatment, but I will mainly speak on cooperation in RCTs, and especially in our RCT that we finished a few months ago. So this is on chronic subdural hematoma. Let's see if I can go to the next slide. Yeah. So we have 11 neurosurgical centers in the Netherlands. And some of these centers had the idea to start an RCT on treatment of chronic subdural hematoma. And we compared dexamethasone versus surgery versus burhole craniostomy. So the first center that started this study was the region of Leiden, The Hague, the area where Dr. Pul also works. And they started the Dexa trial. That's the trial which compares dexamethasone therapy in symptomatic patients with a chronic subdural hematoma. And they compare it to burhole craniostomy. So the hypothesis was that surgery will have a superior effect on functional outcome compared to dexamethasone therapy. So these centers started it. They received funding from 2 foundations. And they started their trial in 2016. So these other 4 regions actually had the same idea, but was slightly different. The name of the trial is different, the CHERISH trial, but also the hypothesis was a little bit different. We said that dexamethasone, because I'm from Rotterdam region, we said that dexamethasone is as effective as surgery at lower costs and with less complications. So we worked together with 3 other hospitals. We received a grant from Erasmus Medical Center and also received a grant from the Netherlands Organization for Health Research and Development. So these hospitals had to work together. That's what I will call it ZON-MW. We had to work together because else we would not receive our grant. So working together with 2 seemingly different RCTs, that's a little bit of a problem. So we have the Dexa trial in Leiden and The Hague and the CHERISH trial in the other 4 regions. So if we compare them, we see the hypothesis is different. It's a superiority study versus a non-inferiority study. Dexa study aimed to include 170 patients and we aim to include 420 patients. Dexa trial already started. They already included 120 patients. And we did not include any patient yet because we first had to have cooperation with the region of Leiden and The Hague. That's what our what ZON-MW asked from us. So yeah, 2 different trials. How can we meet the requirements of ZON-MW to merge these 2 studies? So that was not easy. What we did was focus on making contracts because, of course, if you want to agree on things, you have to write it down. So legal advisors came in, we discussed and commented and had ideas, had to have a lot of meetings with a lot of questions and more ideas, and everyone has its own important points that they really want to have in the contract. Let's say this was not easy. This took over a year to have it all together, but finally we had this agreement. So this agreement was made between those regions. The study was not called CHERISH anymore. We kept the name of the Dexa trial because already 120 patients were included, and we had wanted to have it all the same, on the same name. But the hypothesis changed. So it was now a non-inferiority study. So the region of Leiden-The Hague had to leave its first hypothesis that dexamethasone is superior, and we went to the non-inferiority hypothesis. So now it is a multi-center RCT with 420 patients to include, and with two primary outcomes, because we had to merge the studies, and we thought that not only the functional outcome at 3 months was important, but also the cost effectiveness at 12 months. So the main problems and main solutions, financing it was a problem because not every region had the same grants. So how to divide that? So we decided on sharing costs concerning the inclusion of patients. I think that was the most important thing. And we have 3 PhD students on this project. And we discussed on how to finance that too. So the follow-up of the first Dexa trial was 6 months, but now we want to follow up until 12 months. So we had to add those follow-up moments and also change that in the protocols. The research nurse, that was someone who called all patients by telephone at 3 months. And we decided to have this one research nurse for all centers. So every patient would be called by the same research nurse. And of course, that also had to be financed, and we also had to agree on that point. So there were also differences in secondary outcomes. And of course, we had to adjust that also in the protocol and in the database. And well, we had to accept that from the first 120 patients, there are different data than from the rest of the patients included afterwards. And then the thing that there's 3 PhD students. Well, I think it's really good that we made a daily board with supervisors of all these PhD students that kept an eye on every PhD student meeting its own goals. And of course, publications, something that's important to agree on before you start a study. We added a publication policy to the protocol, not to the protocol, to the contract. So we decided before starting together who would publish what and which place everyone would get, because first, second, seniors, every place, of course, has to be discussed before starting. Actually, most importantly, what we learned is to build trust, because if people don't trust each other, you can discuss endlessly, but if you do not trust each other, you won't ever reach a contract. And of course, clear communication. If you say something, keep to it and confirm your agreements through contracts and protocols. And it seems very easy, but keep the promises. So if you promise someone a certain place in a publication, or if you promise anything on finances or whatever, you just keep to that, because if some things are vague at a later point, you will have a problem building the trust. So if we go to this Dexa trial, so we finally met each other in the middle, and we had these contracts. And the Dexa trials was finished beginning of this year, and results are awaited soon. Another thing we also did, because we thought, well, we can work together, because we learned a lot through that over a year of communication together. So we also started the Dutch Chronic Subdural Hematoma Research Group. That's our national collaboration on chronic subdural hematoma. And we asked all neurosurgical centers to join us in this research. And our aim is to combine all chronic subdural hematoma studies in the Netherlands, and to convert the results of these studies into a widely supported national guideline. This research group is not on its own. We are part of ICORIC. ICORIC is the International Collaborative Research Initiative on Chronic Subdural Hematoma, established in 2018 on the EANS. So the DSHR is only a small part of this organization. ICORIC was started because there's an ongoing need for future aligned RCTs and evidence-based guidelines in chronic subdural hematoma. And we aim to achieve this through reaching consensus on a core outcome data set. We think it's really important to have core outcome data when you write on chronic subdural hematoma, to have a standardized chronic subdural hematoma definition, because no one exactly knows what a chronic subdural hematoma is. It was never written down. And also to have data elements to be used in future chronic subdural hematoma studies. ICORIC wants everyone to work together, and because we learned a lot from our collaboration within Dexa, I think we are doing pretty well in ICORIC. We try to build trust, we try to let everyone have their points and to listen to everyone that comes in. One of the things ICORIC did was writing a review on all currently running RCTs in the world. And another thing we will actually do this week is we will have a survey on the points that we aim to achieve. So we will send a survey on the chronic subdural hematoma definition and on the core outcome data set. And well, actually, this led to a collaboration within a lot of countries from all different continents. And if you want to join ICORIC, if you want to join this collaborative, you're more than welcome to tell us what you think about chronic subdural hematoma, and maybe you want to join in research too. So if you want to join, you can always send me an email, and we work closely together with the UK, with the team of Angelo Scolias and Ellie Edelman. So we will come back to you when you email us. Thank you. I think that's it for now. Shall we already go to the Q&A?
Yeah, thank you very much, Dana. Excellent discussion. I see some reactions in Q&A, but not a question. But in between, I already have a question for you. I know the beginning was very difficult when we started cooperating in this RCT. You managed quite well, so you could quite well manage all the difficulties there were. But how was it personally for you as coordinator within the study? You had different bosses, several bosses in different universities. I do know you did it very well, but I do know it's very difficult working with people like me. How did you personally deal with that?
I think it's most important to know that everyone has its own agenda. I have my own agenda, but everyone has its own agenda. So if you can build trust, and if you say, well, I want you to reach this, and I would like to reach this, and to see that another one's agenda is as important as your own. Not always be first. Sometimes you can be second or third, or just think along, because your time will come at another moment. And I think if everyone leaves space for other persons, and you can also reach your own goals then, because it's all about collaboration, because we do not do research for ourselves, but we do research to get the best treatments for our patients and not for ourselves. And of course, your co-promoter, he will take care of you, eventually get your thesis done. It will be fine. But I think collaboration is something more than concerning your own thesis.
Yeah, great. Well, you did very well, I know.
Thank
There are some questions. One is with a microphone. Dana Hall would like to answer.
Yeah, they say, what's your email? Maybe I can share that last screen again. My email is on the right bottom.
Oh, okay, yeah. So that's your email address. And Nikolai Tonchev is asking you, do we have some results from this study?
Yes, we do. But we cannot share them yet because we are writing on it. So I'm sorry for that, but we expect to submit our paper in 1 or 2 months. So of course, the Dexa trial, results are awaited, and we are analyzing this now.
And hopefully, besides the publication, also presented in Hamburg.
Yeah, that would be great.
Yeah.
Yeah.
Amir Shoal is asking, is there any consideration putting a drain after evacuation of the chronic subdural hematoma?
Yeah, so actually there's not a lot of level 1 evidence in chronic subdural hematoma research, but putting a drain is one of the things that is level 1 evidence for. So it's still a discussion if you should put a subdural drain or a subgaleal drain. The article that's written, I thought it was The Lancet in 2000, that's a few years back, 2017. But that article said that you should put a subdural drain when operating on a chronic subdural hematoma. But subgaleal drain, some studies say that's even better. But I think that's also why what ICORIC is for. We want to merge all those studies and discuss what we think is best, and we discuss that among our members. So if you want to participate in these discussions, you can email me and we will add you to these discussions.
It's already a kind of worldwide network which you and other young researchers have created, which is good. The next question is, I see there's something coming in another one. That's in the chat box. Look. We see a lot of bilateral chronic subdural hematomas. What's the current treatment protocol to treat this?
There's no treatment protocol. So that's actually what we are trying to do. So with the Dutch Subdural Hematoma Research Group, we want to create a national protocol. And with ICORIC, we want to eventually make an international protocol, but we are not there yet because a lot of RCTs are still running. But if you want to get posted on these developments, because there are a lot of developments on this seemingly easy topic of chronic subdural hematoma, you can always email me and we will add you to the latest news on chronic subdural hematoma.
Great. And I already received another question. It's very important for all the listeners and viewers that you have to post your questions in the question and answer box. Navneet Singh is saying to all of us, we reviewed our data internally, subdural versus subgaleal drain, no difference in recurrence rate, but high complication rate with subdural drains. That was in St. George in London.
Yeah, that's really interesting. We don't know if it depends on the person's placing the drains and how many experience they have with placing the subdural drains. There was a lot of discussion on that at the last EANS, like maybe subgaleal drain is easier to place and maybe that's why there's a difference. So we still have to look into those data. And I think it's interesting if we can have a prospective database in all these participating countries. So we all keep track on our patients and how they are doing. And eventually share all those data. Then we can compare subgaleal drains versus subdural drains. We can compare bed rest or mobilization during drain placement. We can compare the temperature on which your flush is during operation. So I think it's really important to work together within ICORIC, make a prospective database in each participating country so we can share ideas and share data within such a collaboration.
Great. I'm now nearly finishing. There are a few questions, so that will be quick answers because we are running out of time a little bit. Are other institutions able to participate in ICORIC? You already said that. So
yeah.
that's
great. Just email me and I will send you any answers on ICORIC that you want.
Yeah. And Galeb Atame asked, what other medicine is given to both patients of chronic subdural hematoma?
So a lot of other medications are investigated. We published an article with ICORIC on all running RCTs. Another medication that's used is tranexamic acid. We are actually researching that with a Dutch Subdural Hematoma Research Group. And also statins, for example, are used.
Thank you. And the four last questions, Nagesh Shaneb is asking, is there a possibility for neurosurgical centers in low and middle income countries to collaborate with RCTs ongoing in the EU?
always. So it's a bit difficult to work together internationally because there are a lot of rules, a lot of mainly privacy rules. But just send me an email and I would love to work together. And I think it's really important in low and middle income countries to use to participate in these trials, because one of the things is that in those countries it can be really important and cost effective to use medication instead of surgery. But of course it has to work and we have to investigate it.
Yeah, that's quite interesting. I know that group of Cambridge is quite active in that. The last question by Bart de Preitre from Leuven. How to develop good outcome criteria that include quality of life, but also the interference of old age and associated inherent loss of function. And I'm smiling here because that's the discussion in one of the other RCTs where Bart is one of the PIs. So how you can answer it, Dana?
Sorry?
Can you answer that? It's a difficult one.
It's a really difficult one. And I don't think we have the answer to this yet. This is something would be really interesting to the survey for the development of outcome criteria is already done. So I would invite Bart to, when he receives this invitation to this survey, please add this to the comment section and we will take this with us in iCorrect. So just send me an email on this and we definitely have to discuss this. It's a really good criterion, but that's very good that we have a collaboration because I cannot answer this as a junior. So really good to discuss this within the collaboration.
And that's a good idea to have that in the collaboration. It's not only for chronic subdromatomas, but for a lot of acute brain diseases in elderly.
Indeed.
So, okay.
So if we can think about this, then we can maybe be an example for all the other studies.
Yeah, great. Thank you very much, Dana.
Thank you very much. Yeah.
And also thank you for presenting here after finishing your RCT. And hopefully we will hear from you in Hamburg and first of all your publication. So
thank you.
So now if you can stop sharing your computer, now we will ask the floor to Thomas van Essen. Thomas van Essen is also, he's still young, but he's already a nearly finished resident in training. Also originally from Rotterdam. And Thomas came one time to me, he wanted to do neurotrauma research and he wanted to randomize acute subdural hematomas. And I sent him away, I said, you are crazy. But he came back and he tried it in another way. And he will take you with his journey of methodological challenges in neurotrauma research. Thomas, floor is yours.
Okay, thank you, Wilco. So you can hear me probably now, right? So I will present the study design, the study methodology we use to answer what's the best acute treatment strategy for patients with an acute subdural hematoma. So a more aggressive acute surgical approach or a more conservative, at least initially, treatment approach. So most of you probably know Centre TBI, but Centre TBI is a large observational cohort study that included all patients with all TBI severities across Europe during 3.5 years. And one of the goals of Centre TBI was to determine effectiveness of different treatment strategies based on different treatment preference across Europe. One of this being a more aggressive acute surgical strategy versus a more conservative treatment strategy. So most of you know, of course, that evidence for this question is limited. Comparative studies are lacking. And valid comparisons, of course, are difficult to achieve due to the strong unbalance, the strong confounding by indication. And comparative effectiveness research has the potential, at least in theory, to give more definite answers. And as I already told you, within Centre TBI, one of the goals is to use the different treatment preferences by way of using different treatment policies to compare treatments. So as a preparation for this study, we performed a European survey, a so-called provider profiling. And in this provider profiling, we ask each center to answer what their general policy is towards acute surgical strategy or acute treatment strategy of acute subdural hematoma. And as you can see, there seems to be a large variation in whether or not a center uses an absolute size threshold for evacuating the hematoma, like the BTF guideline. So in a more in-depth analysis in the Netherlands and Belgium, we also sent out a survey in which we included 6 hypothetical cases of patients with acute subdural hematoma, in which we asked, would you treat this patient surgically acutely? So the first on the left side is a 90-year-old girl who had a head injury half an hour ago, was brought into the ER with a GCS of E2 M5 V1 with normal reactive pupils and acute subdural hematoma, subarachnoid hemorrhage, and some beginning contusions on the left side. So the second case in the middle is a 79-year-old male who was brought into the ER with an unknown history of trauma, but with a clear head wound. E1, M2, V1 on arrival, and non-reactive pupil on the left side with a large left-sided hematoma with some considerable amount of shift. And the third case on the right side, at the other end of the clinical spectrum, is a 72-year-old male who has a headache, who has a GCS of 14, so E3, M6, V5, and has some slight right-sided weakness. And as you can clearly see in this bar graph stratified per region, there is a clear regional variation towards this acute treatment strategy. So the aim of our study was to determine the effectiveness of an acute surgical treatment strategy versus a more conservative treatment strategy, at least initially. So the design, of course, follows center TBI, which was prospective, observational, multi-center during 3 years. And we used the treatment preferences defined as a case mix adjusted surgical range, which I'll just show you in a minute, to create parallel study groups in an effort to determine effectiveness. GOSE as a primary outcome measure, and standard sample size calculations are not readily available, so we simulated the study, assuming at least 1,000 acute subdural hematoma patients and at least 30 centers with an odds ratio of 0.6 and 1.5. And that led to a power of 80%. So unfortunately, I cannot present all results yet. So the outcome results are not finalized yet, but I can present some descriptives. So first of all, we included 1,400 acute subdural hematoma patients from 65 centers. Acute surgery was performed in a quarter of those, and the majority was treated conservatively initially. And a third of the acute surgical group So next up was to determine, to quantify the tendency to operate per center, per region. And as you can clearly see, there is a large variation in surgical rates in this figure. So dark blue means a lower threshold for surgery, so a higher surgical rate. And what can be inferred from these analyses is they're adjusted for case mix. There is a twofold higher probability of receiving acute surgery for an identical patients in between 2 randomly chosen centers from the study. And an important note here on generalizability is that some patients, of course, will be surgically treated acutely always in each center. So that's important to remember. So then we wondered what the relation was of the predefined surgical policies to the actual observed acute surgical rates. So in multivariable regression with the most important confounders, it was shown that this low threshold for surgery actually had a strong relation with the actual observed surgical rates. So for comparison, one non-reactive pupil was less strongly or similarly correlated with acute surgery. So finally, of course, we needed to know how the baseline of the patients were across these different treatments, different centers. So more or less the baseline was similar, although some factors stood out. As you can see here, the GCS was slightly worse in a more aggressive center, so the category on the right. Just as like the hematome volume of the acute subdural hematoma was slightly higher in more aggressive centers. But in overall, in a summary score, the crash CT score, overall prognosis was similar. So again, unfortunately, I cannot present the association with outcome yet, but at least we can conclude that that there are large between-center differences in tendency to operate, while at the same time having similar patients more or less per center. And an important note that I'd like to say again is that some patients will be surgically treated acutely in each center, and as such they do not represent the study population for which the effect estimate, the future effect estimate, will apply. So schematically it looks like this. So it's applicable to those patients for which the neurosurgeon hypothetically may be in clinical equipoise, or in other words, for which there is more than one valid treatment option. For example, the case of the survey I presented in the beginning, the male 72 years old with an almost maximum GCS with some right-sided weakness. It's one case that is included, that could be included. And another example is a male 70 years old who was on acetylcholine type of warfarin, E2 M3 V2, and with a small acute subdural hematoma with some shift. Of course, the decision here is whether or not to evacuate the hematoma and place an ICP sensor versus only place an ICP sensor. So I think we can conclude that comparative effectiveness research, so this type of observational comparative effectiveness research, by way of this center level analysis of treatment preferences, seems a powerful way of going forward. However, when you want to do this kind of studies, you should remember there are some pretty challenging requirements. First of all, you need high data quality. So not only does the data be very granular, but as you can see, it needs a considerable sample. 1,000 acute subdural hematoma patients, of course, quite large. You need to make sure you understand and can apply the advanced methodology and know that important point is that the applicability of the generalizability might be a problem, or at least take some more time to explain. And last but not least, there should be between center differences in the processes or policies. So as a final remark, I'd like to give some attention to our pragmatic trial to reset acute subdural hematoma, which is another type of comparative effectiveness research we feel, an experimental comparative effectiveness research, and with the goal to evaluate the effect of acute surgery in the elderly with an acute subdural hematoma. We just started including now, and we've including in 6 centers in the Netherlands. So thank you, and I'll give the floor back to Wilco.
Thank you very much, Thomas. For the last trial, the 6 centers in the Netherlands and 6 or 7 in Belgium. And but thank you very much. And before I see the questions have to be sent inside the question and answer box, the Q&A. So within the chat, I can react a little bit, but it's difficult outside Q&A. Before those questions come in, Thomas, with a small joke, I said you came at my office some 7-8 years ago, I think, and asked me to perform an RCT in young people in acute subdural hematoma. Now you know all the problems in CER and also the RCT thing. What do you want for the next 10 to 20 years? What do you say to your colleague, junior neurosurgeons and residents?
Yeah, so you have answered me this question, I think like 4 or 5 times at different occasions, and I tend to answer this question differently each time. So the last time I was very busy analyzing this data of centric TBI and becoming quite disappointed about how I should interpret results and trying to learn this methodology through the difficult statistical program R. And then I said that, well, I think the way forward are RCTs only to determine effectiveness of interventions. But now, a couple of months further on, and discussions among you and Andrew Maas, among others, I feel that these more experimental type of observational studies should really be an important part of the future research paradigm, because it's an illusion to think that RCTs can answer every clinical intervention question. Every burning clinical question in clinical practice cannot be solved with an RCT. So at least that's what I learned from this project, is that by thinking in other ways in RCTs, you're at first disappointed maybe, but in the end, it might be a good solution and better than only RCTs.
Yeah, thank you. To add value also for the patients. There's a question from Nagesh Shambak. He said, hi, is the RESET ASDH trial similar to the Rescue ASDH study in terms of primary outcomes, although in an elderly population?
Thank you. So he's referring to the Rescue ASDH, which is a study that compares primary decompressive craniectomy to craniotomy for patients with an acute subdural hematoma from the UK. Started in the UK at least, but international. So the primary outcome of the Rescue acute subdural hematoma, I think, but I don't know for sure, is GOSE at 6 or 12 months. And just like the RESET ASDH, the primary outcome is also GOSE at least, but the time point may be different, I think. And it's in both ways, in both studies, I think, at least in RESET, I know, of course, it's analyzed in an ordinal fashion.
Yeah, thank you. And there's one of the other questions was still placed in the chat by Savas. I cannot pronounce your name, sorry for that. Savas Markopopoulos. Do you have research for acute epidural hematomas?
So let me repeat the question. Do we have
research
for epidural?
Acute epidural hematomas?
Yeah, so definitely, of course. So there's a lot of studies that have been done. So I'll interpret it as, are there any effect estimates, or are there any studies being done that have led to actual effect estimates of patients with an extradural or epidural hematoma? So I only know of one study, which was actually a kind of proof of principle of using a dramatic effect methodology in traumatic brain injury. So what they did is they compared the modern surgery in epidural hematoma to historical cohorts of patients with an extradural hematoma. And then, of course, as you might expect, the effect estimate was very large. So even like 8 or so, at least an odds ratio. Yeah.
And is it being investigated in a subgroup in center TBI?
Yes. So yeah, and indeed that's an important remark, Wilco. Thank you. So we're also doing led by Dana Psica from Rotterdam. She is investigated it within center TBI, and it's currently also expecting any results anytime soon.
Okay. Thank you very much, Thomas, for your explanation also about the study. So before you run a trial and think you run from RCT to comparative effectiveness research, well, ask Thomas, you will get gray hairs. He still doesn't have gray hairs, but if you see the reaction of people like Andrew Maas and myself after the first tables, it is quite difficult. So this is hardcore methodology, and you have to be aware that it's difficult. And already applaud Thomas for the work until now. Also, his results will be presented in Hamburg, I hope. And the paper will be submitted soon, I think, and then we can present the results, which you are not able to present yet. Thank you very much, Thomas.
Thank you.
And we go to the last speaker of this webinar. Jeroen van Dijk, also a PG student from the Center TBI group and also working in Leiden and The Hague. Always interested in trauma. First wanted to become a general surgeon, which was not a very good idea. And after that, interest in neurosurgery, and very spectacular, he was interested in medical ethics, in very severe brain injury, and economics. So it looks like a strange combination, but it's quite important in this group. Besides the emotional effects, neurotrauma treatment in very severe disabled trauma patients is also very expensive. So we go to Jeroen, and the floor is yours. And you can take a little bit more time because we started a little bit later, so we can go after 6. So take your time, and I see the questions and answers in the box. Good luck.
Okay, thanks, Wilco. Yeah, I will talk about the dilemmas in the treatment of patients with very severe traumatic brain injury. And when there's still time, but there is time, I will say a few words on informed consent in TBI emergency research. So, yeah, it works. So very severe TBI is usually defined as an early GCS of 3 to 5. Patients have a high mortality, low chance for clinically favorable outcome, and are therefore often considered to have a dismal prognosis. As doctors practicing neurosurgery, we all try to reduce the huge impact of this injury by initiating a variety of neurosurgical treatments. And based on my 5 years experience, as Wilco already pointed out, and Thomas as well, these decisions are always surrounded by many uncertainties and are very difficult to make. Guidelines do provide some guidance, but the strength of recommendations suffers from the lack of high quality scientific evidence. So what is expected from us as doctors in medical practice? We are expected to practice medicine by generally following 4 universally accepted moral principles in medical ethics. The first is autonomy. Autonomy of these patients is inherently compromised due to their injury. And when advanced directives are unavailable, we don't know what the patient would have wanted us to do. So we can try to reconstruct a patient's wishes using proxies and act accordingly, but proxies are often absent during the acute phase or incapable or to make decisions on behalf of their spouse. That means that we have to make these decisions and choose a treatment strategy that is best in line with a patient's interests. Serving this interest is what is meant by the second term, beneficence. We have to provide benefit to our patients. And we all know medical and surgical interventions carry a certain risk of inducing harm. And we could, for instance, make it happen that a person or a patient survives with an unacceptable disability. And we also have to adhere to the principle of the third principle, and you have to avoid causing harm. So very severe TBI, what is the outcome of these patients? Do we cause harm? Do we cause benefit? I will show you using the results of a prospective cohort of nearly 500 hospitalized TBI patients that we included in the Central TBI study. And I will show you the 6-month GOSE outcome score of all of these patients. 51 of these patients sustained a very severe TBI and had an early GCS of 3 to 5. As you can see, 34 died. Nearly 20% was able to achieve a GOSE defined favorable outcome, and 3 patients achieved a full recovery, and only a few patients survived with these severe disabilities that we always try to avoid. This figure also shows that although outcome is generally bad, that most severely injured patients are able to achieve a favorable outcome. And yeah, it's not seen in this figure, but I told already that some even achieved the full recovery. It's not new. We also conducted a literature review. The reference is on the right and the below corner. A review of literature that showed that high mortality and a low chance of a good outcome, but also that good outcome was possible. It was difficult to point out exactly what factors contributed to this good outcome, but it seemed to be associated with a GCS higher than 5, absence of pupillary abnormalities, and a lower age was also related to a better outcome. And the immediate or acute treatment of these patients with neurosurgical interventions might have contributed to a better outcome, but we couldn't conclude this based on this review. But I think it's important to highlight that it is possible for patients to achieve a successful recovery, because the mainstream focus on high mortality and unfavorable outcome rates, it contributes to an overall belief that aggressive treatment is not effective. It has a risk of becoming a self-fulfilling prophecy and a non-belief, which can only lead to a decrease of treatment intensity or treatment limiting decisions that further negatively influence the outcome of these patients. So the next question is, of course, what is good outcome? It's also the question that Professor de Preiter asked to Dana. How can we classify good outcome? So what outcome is good, what outcome is not good? Valuation of this outcome is probably one of the most difficult, but also one of the most important aspects of decision making. Most TBI studies and prognostic models used GOSE, the Glasgow Outcomes Score. This is uses a definition of favorable outcome, that is that patients live independently, and unfavorable outcome is defined as the need for assistance in daily life, which can be seen on the table on the right. Favorable outcome is good, unfavorable is bad. There are many examples in literature where the GOSE definition of upper severe disability is considered to be favorable, whereas most physicians or researchers or many people who are listening to this webinar would have classified this outcome as unfavorable. And when asked to competent individuals, they would consider a survival with unfavorable outcome unacceptable, but severe TBI survivors with the so-called unfavorable outcome after a decompressive craniectomy, they appear to change their definition of a good quality of life. And they asked them, would you have provided retrospective consent to this neurosurgical intervention? And they said yes. And not only they said yes, but also their proxies said yes. All those references can be found in the reference on the right down corner in that article. But this absence of a linear connection between this disability and the experienced quality of life, that's a very known fact. I never heard of it before, but it's called the disability paradox. And it's not new. It's also described in patients with the locked-in syndrome or patients suffering from Duchenne's disease. And it's caused because healthy individuals, they often underestimate their ability to adapt to levels of a disability they previously considered unacceptable. And they appear unable to predict accurately what future quality of life would be most acceptable or unacceptable for them. So this cutoff point of favorable and unfavorable, as Wilco already mentioned in his introduction, which is in the cutoff point that is used in the TBI studies, it does not necessarily represent an acceptable or an unacceptable outcome for patients. It just does not seem to include all the subtleties of outcome acceptability. So determining a new or a better cutoff point is very difficult because of there are many possible outcomes, and there's substantial variation in people's changing desires and interpretation of a good life, and the variation of the injury is also huge. But it's crucial to increase our understanding of the acceptability of outcome and what outcome is acceptable. So we can measure outcome measures, but we also have to take the consequence of describing an outcome measures. And when we say this is the outcome, we also have to judge what does this outcome mean and what do we do after having made this outcome. So we should try to find, or at least approximate, the definitions of acceptable and unacceptable outcome. The only thing that is certain is that the unacceptable outcome for us as doctors may not necessarily be unacceptable to our patients. And I think that's something we could realize more often. There are a lot of remarks on outcome, but let's assume it's possible to achieve a so-called acceptable outcome after very severe TBI patients. We also have a responsibility that extends the responsibility for our patients. Justice as last moral principle. It not only requires the fair distribution of benefits and risks, but also of the limited medical goods and services. So we can all imagine that too much focus on the benefits of a single individual with performing against the odds heroism can be in conflict with the overall performance of the entire healthcare system, which negatively influences other patients. So following justice, resources should be restricted in some cases when they are used on ineffective or disproportional treatment efforts, as it will deprive other patients of potentially effective treatments. And these are very hard decisions. So let's see what the costs are. We have also calculated the healthcare consumption and the in-hospital cost of these patients that were included in the Center TBI study. The mean cost of all TBI patients was nearly 12,000 euros, ranging from 8 to, for mild TBI patients, to 26,000 for very severe TBI patients. And costs increased with a higher TBI severity, the presence with intracranial abnormalities, extracranial injury, and surgical interventions. Because these costs, as you can see in this figure, are primarily driven by admission, followed by surgery, radiology, and labs. I will show you the next slide. I think I missed a slide. Yes, so as can be seen on this slide, the costs of TBI are high compared to other diseases, but not exceptionally high. So I think that the in-hospital costs for these patients seem acceptable when compared to other diseases, but I don't know. It's only about in-hospital costs, so it's a major underestimation of the actual total cost after TBI. These are much higher. Think about chronic care costs, rehabilitations, the loss of productivity of patients. So unfortunately for TBI, there's evidence on cost effectiveness. There is evidence, but the evidence of the intervention cost effectiveness is inconclusive. Some studies say it is cost effective to perform a decompressive craniectomy, and other studies say it's not cost effectiveness. So this also requires further evaluations. And again, we have to establish a point where patient TBI is so severe and patient outcome is so unacceptable that it does not justify the enormous healthcare costs that are associated with the treatment of these patients. And it's maybe a harsh thing to say, but it is really necessary to establish a point like that, because healthcare costs are increasing worldwide, not only in the Netherlands, not only due to the COVID pandemic, but it is happening for years, and healthcare budgets are limited, and we have the responsibility for the whole and for the entire healthcare system, not only for our own patients. So we really have to think about that, is my opinion. So that brings me to 3 conclusions for the first part of this talk. So yeah, I will read it. Future research is needed to identify specific subgroups of patients in whom aggressive surgical intervention is cost effective and will result in good outcome, preferably with a certainty that can be used in multidisciplinary decision making. And until that time, although a limited endeavor for sustaining life seems unrealistic, treatment limiting decisions should not deprive patients of a chance on achieving an outcome they would have considered acceptable. And a more reserved attitude regarding this aggressive therapy may be justified in patients whom a combination of different features indicate a very low chance of regaining an acceptable quality of life, and no signs of any improvement exist following an initial optimal therapy. So to elaborate on the 3rd conclusion, we explored and described the process and reasoning of decision-making in several focus groups. And we have proposed several reasons that could legitimize treatment-limiting decisions. So I want to show you a table that was the result of this, that was published in this publication. And this table contains reasons. Well, it includes potential outcome, perspective in which treatment limiting decisions should be strongly considered. So the first is brain death from a patient's perspective, so not considering interest regarding organ donation. The second is an unresponsive wakefulness syndrome, a minimally consciousness state, an available, unquestionable written and signed specific advance directive of the patient, a proxy's opinion that is also unquestionably based on a patient preferences and not in conflict with the medical team's considerations, and a patient's view that is, well, it can be a reconstructed vision through surrogates on life and quality of life. And as a last point, the treatment costs along the whole chain of care that are not cost effective and higher than the maximum amount that has been decided by national legislation. And of course, this table is up for discussions, and not all physicians will agree with all of these points. But I decided to show it anyway, because I think it's important to discuss these issues. And this is also a platform for discussion. So please let me know if you disagree or have any suggestions, or you want to join us in thinking about this subject, because I really think it's important, and I can only imagine you agree on that. So how to optimize future research. The next part is on informed consent. So it's a new subject.
You have only a few minutes left, Jeroen. So
yeah, I know. I'll try to hurry.
Yeah. Important subject, but very, very shortly.
Yeah, so it seems obvious, but there are solutions that are needed. And one of the problems in performing research in TBI patients is informed consent, an ability to obtain patient-informed consent. So that's why we wrote a policy view, a personal view, on informed consent procedures in emergency intervention. So when my time is up, you can also read this paper, and then you are informed, also informed. So patient-informed consent, it's an ethical cornerstone of research involving humans. Patients with severe TBI, they have a limited ability to make or communicate their decisions. Yeah, they are often not possible to include in a study. Most patients suffer from these neurological deficits or sedation, so that's impossible. Awaiting recovery is also impossible because study interventions usually need to be delivered in a very short therapeutic time window to be effective, and any delay in administering these interventions could also compromise its effect and thereby invalidate the trial design and trial outcome. And on the other possibility, what happened a lot is that excluding these patients is no solution, as it causes selection bias or limits the external validity of the study results. So what makes consent valid? So there's a table. First, disclosure. It means that a patient or proxy should be provided with a complete understandable information about the purpose, duration, potential risk or benefits, and possible other consequences of the study. They should fully understand it. They should be free in making a judgment, and they should have the intention to participate in the study and are provided with sufficient time to provide consent. And as you can imagine, in TBI emergency research, there's a problem with nearly all of these conditions. So to see what consent procedures are used in recent trials, we examined a sample of RCTs in emergency TBI, and generally there were 3 alternatives to patient-informed consent before intervention. And the most commonly used alternative was proxy-informed consent in 92% of the trials. And that is usually provided by an individual who has the legal right to provide consent on behalf of the patient. But there are several issues. They aim to make a decision that is authentic to the person they represent, but you see that it's also compromised by the short therapeutic time window that precludes the consent conversation to happen. Proxies cannot always be located in a short matter or contacted. And proxy decision-making is complex. It's although they want to be involved, empirical evidence also suggests that they might not always be suitable as a surrogate decision maker. And more details, I will refer to the article. So the challenges are the short therapeutic time window, the deficits caused by TBI, and the frequent lack of available and competent proxies. So based on our literature review, consent alternatives seem to be increasingly used also, but they also seem to be very much needed in the future research initiatives. So the first alternative is deferred consent, only used in 13% of trials. And it allows participants to be included in studies when patients or proxies are unavailable to provide valid consent. And after starting the procedures, consent must be obtained for study continuation as soon as they regain their ability to provide consent. The procedural particulars are always difficult and always different and depend on local legislations and requirements from the institutional review boards. But unfortunately, it was infrequently used. The next is exception from consent, and it's almost the same. A study can also start without prior patient or proxy consent, and information should be communicated with patients or proxies at the earliest opportunity. But this procedure can be necessary when patients are exposed to continued or prolonged study activities without being able to consent, and then patients can be kept in the study. Both procedures are very much have a high score of acceptance. So a solution, this is the last slide, Wilco, if you allow me. So clearly there's very difficult.
It's quite a busy slide, Jeroen.
Yeah, I know. I will keep it short. So clearly, selecting the appropriate informed consent procedure for a study is very difficult. It depends on local legislations, on institutional review boards, on study details, on the methods, interventions, patient characteristics. And they should be used as an overlapping and complementary strategy to solve all the difficult and all the different challenges of a study. So I would rather see it as designing a tailored informed consent strategy. So we designed a flowchart. It's to provide some guidance in designing an informed strategy, and as first step, researchers should determine whether the therapeutic time window allows for an informed consent procedure. And when there is time, it should be determined whether it's feasible to obtain valid consent within this time window. And if both are answered yes, you can use patient or proxy consent. But if both are not practicable, the timely determination of a patient or proxy's wishes should be considered not possible, and therefore you can use alternative procedures. It all depends on the particulars of the study and local legislations. My time is up. Thank you very much. More details in the article.
Thank you very much, Jeroen. It's quite a difficult subject, and I asked a lot of you because I want to discuss very severe TBI and also informed consent, which is nearly impossible in a quarter of an hour. But I think you did very well. One of the most important questions, I had one by WhatsApp and the other one by question and answers by Corrado Iacarino. He says, well, and that's alluding to what you are saying in the last slide, last few slides. It's very difficult to propose the enrollment of comatose patients in research studies. Ethical committees allow the enrollment with high grade of bureaucracy. Sometimes it's impossible to enroll patients even with families' informed consent. And that's also something I discussed with other surgeons also in Italy, and I saw also together with Corrado, that some people think that in our country a lot of is possible. What do you think of this perspective, Jeroen, at the European level? If you look at the possibility to have this deferred consent.
Yes, if I can share my screen again, I expected this question, and I have in my presentation a slide from Center TBI data, which shows that deferred consent is an accepted procedure in a lot of European centers. And that's seen in the upper table. So this is from the patient profiling questionnaires, and then the principal investigators answer that the deferred consent procedure is possible for this particular study in 83% of the cases. But when you look at the actual use of the deferred consent procedure, you see that in the ICU, only 16% of patients was included using the deferred consent procedure. So there is a mismatch in that. But I think European law is very clear. It is possible in certain circumstances, and yes, but it's not known enough, I think.
Yeah. Okay, thank you very much. In between, also Niklas has been active the past half hour. He's the chair of our neurotrauma section. What this past hour did show us, of all three of you, is that research is very necessary in TBI, and there's more necessity too, because without research we cannot reach the added value for patients. And I also finalized, because before I give the word to Niklas, because he might have the final word for the next webinar, I don't know. But Corrado, the one who asked you the question, Jeroen, just shortly before, he said, well, in its WhatsApp, large different surgical indication among centers seems a failure of guidelines, ... And indeed, the outside world is looking at if there's a huge practice variation, it's a sign of low value care. I think that the guidelines cannot be correct because there's not enough evidence. So I'm very happy that in Europe, but also the rest of the world, people are becoming more active in doing this kind of research in brain trauma, because we need it. And I also hope that a lot of listeners today became enthusiastic, because you are the young researchers, you are the future, and that you had the word. I thank you all three for this, I think, beautiful presentation. And now I give the word final back to Niklas. Niklas, do you want to say something, or for the next webinar?
I'm not sure I need to say something. I don't know if you hear me. I actually missed the first part of it because of poor grade subarachnoid hemorrhage that came into our neurocritical care unit. So, but thanks, Wilke, and your team for a fantastic presentation. And I hope everyone who listened, we had a good number of attendees here, which is excellent. And I think if we should encourage all of you to attend also our next webinar, which is in June 10th, for Alexander Jones and his team in Heidelberg on spinal cord injury. And then after the summer, Andreas Bucke also was here attending. We'll have a webinar on biomarkers. Neurotrauma is, after all, the most important and interesting topic of neurosurgery. So draw attention to the ENS meeting in Hamburg, to the Lund meeting, ENS Trauma and Critical Care meeting, December 13 to 14. And also the recently established European Neurotrauma Organization. Myself is one of the founding vice presidents. So it's a lot of neurotrauma happening in Europe. And, you know, we can continue to be a leading force in the world, I would say, in Europe. So excellent work, Wilke, as always. So I guess you want to say something about brain and spine. When can we start submitting to brain and spine?
Within 2 months.
2 months, okay. Good to know.
Probably next month it will be open. So, yeah. Okay. Thank you all very much, all the listeners, and also for the quite enthusiastic interaction. And hope to see you soon in probably live in Hamburg, or otherwise with your submitted papers in brain and spine. Thank you very much. Bye-bye.
Bye.